deformity. You see here a patient long face syndrome, obtuse gonial angle, aesthetic is not well. Also, syndromatic cases. We have Dr. Hatim is an expert in cleft surgery, and even with more severe cases, midline cleft and many, many other cases. So we have very wide range of movement. Next, please. Accordingly, we have also a lot to offer to this patient. If the case is diagnosed early in life, we can do dentofacial orthopedic. For cleft patient and palate, we have cleft, lip and palate surgeries. We have many operations. And even for craniofacial deformities, we have craniofacial osteotomies. But in this lecture, I will concentrate on orthognathic surgery and distraction osteogenesis. Next, please. لا مش للأسف. Yeah, and on and off. What we do in orthognathic surgery, we just separate the bone, the two spearing area of the jaw from the cranial base and put it in new position and fix it with plate and screw. You see here the plate after Lee-Fort 1 osteotomy. We can do this in the mandible. We have many osteotomies, but I will not go into details in this. Here we have Lee-Fort 1 osteotomy. ده بيغير لوحده. Symptomatic. And in the mandible, we call it sagittal split osteotomy. You don't need to know the exact technique of this. Here in the maxilla, we have a very well-established surgical technique. It is safe if you are trained, and most of the maxillofacial surgeons are trained in such surgery. And you see here, هو يغير احسن. Okay, next please. لا الأولانية بس. The previous one? Yeah, no. Next one. Okay. Yeah, you see here the maxilla. This is the nose. This is the lateral wall of the maxilla, and this is the maxillary sinus. We call it downward fracture, a leaf at Lee-Fort 1 level. In the mandible, we do sagittal split. This is the most commonly used technique in orthognathic surgery. And you see here a defect. This is not really a defect. It is just a defect on the buccal side. Because the lingual side is intact, we have a special technique to cut only in the buccal side, and we leave the lingual side intact to promote healing. Next, please. For a good result in orthognathic surgery, we have a very close cooperation with the orthodontist. And the way to do this is different. Sometimes we do surgery first, and then the orthodontist will complete the case. Why? We put the maxilla and mandible in a class 1 relationship, and then the orthodontist. This is now the trend now. Before, we have to do orthodontic treatment, and then surgery, and followed by orthodontic treatment. Or sometimes we get cases from the orthodontist. He tried to treat the patient, but he didn't get enough good results and refer the patient to do his osteotomy. Next, please. Now we can get very good results because of two things. First, the introduction of rigid fixation. Before, we have to fix the maxilla and the mandible with wires, and we have to close the patient's mouth. We don't need this anymore. The patient is operated, and after surgery, he can go out of the operating theater while he is opening his mouth. We have a computer prediction, and we have now 3D virtual planning and construction of surgical splints. Next, please. We have two methods to construct surgical splint and to do model surgery. What is done in the model surgery? We just here take impression. This is here the analog model surgery is the old technique. What I prefer till now, because the virtual planning software is not well developed as we would like to have. Here first, you see here, this is semi-adjustable articulator. We take the impression, we cut the tooth-bearing area and put it in new position, and we have to construct what we call it surgical splints. Why we use surgical splints? Just to guide us, to produce exactly the motion we would like to have in the patient, the operating theater. We cannot measure in the patient mouth during operation. So we have to construct 1 to 3 surgical splint during surgery. This is very time-consuming procedure. This is, This is very time-consuming, and sometimes we have error because we separate the tooth-bearing area from the base of the model, and to put it in 3-dimensional, it's not easy. So I thought about something to help us doing analog model surgery without separation of the model. Next, please. Without separation of the model from the articulator. Next. No, next. This is the previous one. No, next. Next. Yeah, this is Khalid Said surgical simulating instrument. It is a surgical simulating instrument instead of the model surgery, and I have a patent in 2011. This is very simple apparatus to use to do the model surgery. How it works here, if we activate this, even is not working well, huh? If you activate any of these nuts, you will move the model into a direction you would like. You can move the model anteroposterior, transverse, and even rotate and up and down. Yeah, we have now the computer-assisted orthognostic surgical planning. You see here the patient pre-operative, and we can put the patient photo and X-ray and combine them together and simulate the surgery, and we see how the patient will looks like after surgery. Here the patient, here, pre-operative. This is the simulation. This is 2 weeks after surgery, and this is 3 months after surgery. It is exactly the same, but it is not the same in every case. Next, please. Another case here, reversed bite, mandibular prognosis, but the problem was in the maxilla, and we advanced the maxilla, the patient pre-operative simulation, and the patient actual post-operative photograph. Next, please. Sometimes we can operate a patient with severe deformity of the face. Here we call it long face syndrome. Is very long face, protruded maxilla, protruded mandible, and retruded maxilla. We need a lot of work to have good results in this case. Please, next, please. Yeah, see how much the difference between the maxilla and mandible, about 18 millimeter. We split this difference just to have stable results. We have to move the maxilla a little bit and retrude the mandible a little bit, and then we have stable results. Next, please. This is a simulation, so I don't trust this software completely, 100%. We don't normally give the picture to the patient because he is dreaming of it. Sometimes they come and ask it to make a face of Haifa Wahbi or something like this. Next, please. In this case, I used my apparatus. Here, I can move. It's weak. Yeah, I can move here to move the cast anteroposterior. I can move here to make the lateral movement and up and down movement. Everything I can do this with this apparatus. Next, please. This is a patient pre-operative. We did the maxilla and we did operation in the maxilla and the mandible. We call it bimaxillary surgery in the same operation. You see, this is a patient pre-op and the patient after surgery has a harmony in his facial structure. Next, please. You see how he looks like. He's also not the smartest look for anybody. So he has a psychological problem and he has to suffer for a long time. Next, please. This is occlusion. Yeah, this is our key point for success of our surgery. Next, please. Another patient, but here maxillary protrusion, mandibular retrusion, underdevelopment of the chin, the patient post-operatively. And you see in each patient, we see a complete difference in attitude of the patient, in the psychological states and self-esteem of the patient, and he's also reacting well to his community. Next, please. The patient, even older patient, they come for asking for orthognathic surgery. She was 38 years old, but why she is late? Because she didn't have the money and the parents didn't want to do surgery, or they thought that is a dangerous surgery for her. Next, please. Fine, we can get good results with orthognathic surgery, but we cannot do all the cases because we don't, the orthognathic surgery, in orthognathic surgery, we don't elongate the soft tissue. We stretch the soft tissue. We have to keep the bone, in all cases, attached to the soft tissue to be vascularized. Otherwise, we will lose the vascularity and the bone will necrose. And this is dramatic complication of orthognathic surgery. And also there is a relapse because if we stretch the muscle, we don't elongate the muscle, we just stretch the muscle will recoil again and pull the bone back. Also the advancement is limited, cannot be done in children. We have to wait until puberty, and there is a possible disturbance of sensory nerves, and sometimes it needs bone grafting. Next, please. Yeah, this is very bad surgery because the surgeon, you see, this is a maxilla. It was a maxilla because the surgeon tried to move the maxilla too far forward and it becomes devascularized, necrotic, and the patient lost all the teeth and all the maxilla. It is a nightmare for any surgeon, I'm sure, for the patient. To reconstruct this patient is very difficult. Next, please. Yeah, another case, we cannot apply orthognathic surgery in this case. You see here how the maxilla is retruded. It's about more than 2 centimeters, 20 millimeters, and we cannot move the maxilla too far forward. Next, please. Also syndromatic cases, we call it hemifacial microsomia, underdevelopment of one side of the face, absence of the ear, and with orthognathic surgery, we cannot do this. We have to do bone grafting, costochondral graft to open the patient chest, but with distraction osteogenesis, we have the opportunity to do better results without bone grafting. Next, please. Yeah, where is the solution? The solution comes from orthopedic surgery, from orthopedic surgeon called Lazarov technique. What we do in dentistry for a long time, but we didn't recognize this. This is a problem. Because in orthodontists, they open the suture. What he did, he just induced a suture here. You see, osteotomy, just induced in a long solid bone, just osteotomy and produce a soft tissue between the two bones. This is what he did. And now he is in the history, and we بعت مننا الفرصة ان احنا ناخد الانفنشن ده واحنا بقينا ناخد منه ونكمل عليه. Next, please. How it works. ممكن شغل فيديو. enter. No, 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 no. This is the video. How it works. Here, this tractor, we call this tractor, 2 arms, one in front of the osteotomy and one behind. And you see here the osteotomy. And you see here we can activate and we get increase of the callus that formed between the bone segments 1 millimeter every day. And in the same time, we elongate the soft tissue, we elongate the nerves, and we elongate everything. You see, we have this test should be done during surgery to be sure that it works well. Here, this is the callus will form, and the callus is soft tissue, and we can stretch the callus. If we don't do osteotomy, we can stretch the bone. Yeah, we go back, and we keep this. We have activation period, 1 millimeter every day, and then you can imagine we can achieve about 20 millimeter in 20 days. Exactly, the bone has the same quality as the other bone. Next, please. So in maxillofacial distraction, we can distract the mandible, the maxilla, bimaxillary, the midface, or even the craniofacial skeleton. Every bone could be distracted as an orthopedic surgeon. Next, please. Yeah, we have now a lot of distractors. For each bone in the maxilla or the mandible, we can distract the ramus to elongate the ramus. We can distract the body. We can distract both together bidirectional, and we can widen the mandible to increase the width of the mandible. Next, please. Also in the maxilla, we have the extraoral outside the face. It is a big appliance. I don't like it. And we use now more the intraoral appliance. We have this appliance to widen the palate. And we have, even for implant, alveolar distractor. Next, please. Yeah, I like to show this case because it shows us how distraction, osteogenesis, it changes our way of thinking to treat such patients. This patient we see every day, lack of space. If you refer this to orthodontist, he will tell you, just extract the premolars and try more or less to expand the maxilla, but he will not expand. What he is doing is just tipping of the teeth, and this is very dangerous because of bone resorption. And in the mandible, the same as in the maxilla. Now we think in different way. Next, please. We just do osteotomy, and we call it surgically assisted rapid maxillary expansion. We do just osteotomy. The surgery is not too big as an orthognathic surgery, and put a distractor in the palate, as you see before, and also in the mandible, we can widen the mandible just to keep the good relation between the mandible and the maxilla. Next, please. That's the arch form after distraction without any extraction. You see here the premolars, the premolar very well aligned teeth. In the mandible also. Next, please. Here you see. Next. That's where we started. V-shaped palate and V-shaped arch and everything. Next. That we achieved after distraction and orthodontic treatment. Next, please. Yeah, you see here the importance of distraction. You see here the flattening of the face, V-shaped or triangular face doesn't look nice, but if we do only orthodontic treatment, we will not get better results in the facial profile of the patient. Next, please. You see here fullness of the cheek and better appearance of the chin. Next, please. Okay. Yeah, we'll go fast. We lost a lot of time. Huh? I have 3 or 5 minutes. I have a stopwatch. Yeah, next, please. Yeah, even asymmetrical cases, cleft patient, you can use a distraction, osteogenesis. Next, please. Yeah, this is his tooth-borne. We don't, normally I prefer the tooth-borne, the bone-borne distraction, not the tooth-borne, because the orthodontist, they use palatal expander. But it is not fine like this because there is no affection of the teeth, we depend only on the bone, and you see here how much we achieved and the good relationship between the maxilla and the mandible. Okay, next please. Yeah, V shape. We see a lot of these cases. Next please. If the patient is adult, we cannot do any expansion of the palate. Yeah, here, the palatal distractor. After doing osteotomy on the buccal side, it is, we call it minor surgery. It's not too big surgery. It doesn't take long time, and it's very safe. Next, please. Yeah, here, after opening, and we achieve here, we get here more space to arrange the teeth. Next, please. Yeah, sometimes you ask yourself why I choose this. You got this case. It is a nightmare for a surgeon. Why? The maxilla is divided in three. This is a medical student. The maxilla is divided in three pieces. You see here the premaxilla is completely detached from both sides. They are only overlapping. We cannot do bone grafting. It is only attached to the nasal septum. And if we do orthognathic surgery to rearrange this segment, sure, we will end up with necrosis of the premaxilla. So before the era of distraction osteogens, it was difficult to treat such patient. What we did, just to rearrange, to expand the palate with distractor. Next, please. Yeah, here we did osteotomy in the buccal. We didn't touch the anterior segment, so we have to expand. This is a part of tongue flap did somebody else. Next, please. So you see here a good arrangement of the maxilla, all in one line, and this case has been published in the International Journal Oral Maxillofacial Surgery, and we did a protocol for severely collapsed maxilla for alveolar bone grafting. We have here mucosal graft. Next, please. Yeah, that's where we started. This is after distraction. We rendered it normal arch. We can start now with our bone grafting to take bone from the hip. Next, please. Yeah, this is the bone grafts, cancellous bone graft from the hip. Next, please. Yeah, that's what we get at the end. Next. That's where we started. Here, 3 pieces. Now we have 1 piece, and the orthodontists can move the teeth inside the grafted bone. Next, please. Another case, unilateral collapsed maxillary arch. Next. Yeah, here sometimes we try to close the alveolar bone, but not to put bone graft, just to help us to produce a good soft tissue in this area, and we put a distractor, and this is the osteotomy. Next. Yeah, we close the defect, and we just try to distract to expand the maxilla. Yeah, please, next. Yeah, here, after distraction, we put bone graft. Next, please. And then we go, next, please. We go to do also the nose after finishing the alveolar bone. Next, please. Yeah, here, the patient with mid-face deficiency, cleft patient, and the patient after distraction. Next, please. Yeah, this is appliance that I don't like anymore because the child has to wear this for a long time, about 3 months, and he cannot sleep well. So we use now the intraoral distractor. I'll show you later. Next, please. The patient after distraction. But the advantage of this appliance, we can pull the whole mid-face. We can do major distraction if we need. Next. Yeah, no, go back one. Yeah, here you see here the lateral cephalometry, how far back is maxilla. Next. Yeah, here, intraoral distractor instead of this big one. Okay, next, please. The patient pre and post. Next. Next, please. The mandible. Okay, we'll go through fast again. Next, please. Patient with asymmetrical face. One side is larger than the other. Okay, okay. Next, please. Extraoral distraction. We use sometimes extraoral or intraoral, but I prefer the intraoral one. But this is just a case we did. Yeah, please, next. Yeah, it looks not nice after extraction of the appliance, but after a few months, you will not see the scar. Next, please. Oh, the patient after 6 months. Next, please. Yeah, I like intraoral mandibular distraction devices. Next. Yeah, the patient was severe mandibular micrognathia due to long-standing ankylosis in both sides. Next. Yeah, here the patient pre-op. The patient after distraction. Still, we need just genioplasty, but the patient was satisfied with the result. She didn't return to do genioplasty. The patient, you see here the lower face, there was no lower face. Now we get bone without bone grafting, with just from the distraction. Next, please. The advantage of distraction that we do it in early childhood. We don't wait to wait until the puberty of the patient. Next, please. Here, intraoral distraction, and this is the osteotomy side. We do it in one side, and we correct. Sometimes we open more in one side than the other. We have every day, you check the patient, you see if it is okay or not okay, and you can go back. It is a soft tissue. Next, please. Yeah, the patient, you see how much the difference between the look of the patient, how they act, the psychology of the patient. Next, please. The self-esteem, the patient occlusion is very well. Next. So distraction osteogenesis opens maxillofacial surgery, new possibility of treating patient with severe dentofacial deformity with lower complication than orthognathic. It doesn't replace the orthognathic surgery. It has this has its place and this has its place with high degree of success and low degree of relapse. Next, please. So in distraction, we go slowly but sure. We have to reach our goal. It takes a longer time than orthognathic surgery. The treatment takes about 3 to 4 months, and we need 2 operations to put the appliance and then remove the appliance. Thank you. Next. I'll come for this.